Good morning. The objectives of our studies. To identify key gene polymorphism associated with pediatric urolithiasis, and to analyze the prevalence and the potential impact of this gene on the risk and severity of pediatric urolithiasis, and how far we can establish a foundation for future research into personalized treatment approach based on genetic factors. Through a 4-year period, the study involved participant recruitment from local healthcare facilities, focusing on children diagnosed with urolithiasis. The others consist of healthy individuals without any history of systemic disease who were also enrolled as a control group. Genomic DNA samples were collected, and amplification refractory mutation system PCR was employed to genotype. The colony-stimulating factor 1 G polymorphism was designed in this study using the National Center of Biotechnology Information and single nucleotide polymorphism database. You know this is a public archive, and ARMS PCR primer 1 design online. Why we choose this gene? Colony-stimulating factor present is a Homo sapien gene present all over the tissue and a specified amount in urinary bladder and in kidneys. And some researchers highlighted in literature that deficiency and alteration of this gene may weaken the suppression of renal crest deposition. In demographic characteristic of the patient and control images were closely matched in gender and age distribution. We think this matching reduces potential confounding variables and ensures that any observed differences in clinical outcome between the groups are less likely to be influenced by gender and age. Here in this image, we can announce how we can decline the pattern of this gene in its wild and mutant type and heterogeneity type by using the ARMS PCR with its specified primer. All data translated by using the SPS version 2023, and here we can highlight those who carry the heterozygote or homozygote gene with C alleles, considered as etiological risk, and etiological fraction is very high, with confidence interval and odd ratio is highly significant. Again, when we verify this allele, we can see those who carry the A1 allele, we can consider it as a preventive factor, and those who carry the C allele we consider as a risk factor. We agree with our limitation as a pilot study. The sample size may be limited, and how far the result provide a foundation, and hopefully the result provide a foundation for further investigation in this area. The genetic predisposition to pediatric urolithiasis may involve interactions between multiple genes. Possible confounding factor that could influence the gene-environment interaction honestly might not be fully captured in this study. We can conclude the study suggests a synergistic effect of multiple risk alleles that increases susceptibility to pediatric urolithiasis, particularly when these alleles are commonly found with the same family.
Meta-analysis of long-term outcome and urology.
Thank you. Good morning, everyone. It's a pleasure for me to present our meta-analysis on fetal cystoscopy with developmental shunting. The LUTO is a prenatal ultrasonography finding, only distending bladder, and it's scoring about 3 out of 10,000 pregnancies, and it's correlated with a high risk of prenatal mortality and long-term morbidity. In fact, the rate of prenatal death is about 35–55% of the cases, and we also notice a high risk of end-stage kidney disease. So, in some select cases, according to the LUTOS agencies, we can propose a fetal intervention, such as the fascicle shunting, that is the gold treatment for Druto, and we demonstrate that they reduce the incidence of postnatal mortality, but the complication occurs in more than 40% of the cases. And on the other hand, we can perform a fetal cystoscopy, permitting a more physiological drainage of the obstructed bladder, and in the meantime, and also examination. So the animal decided just to compare the survival, nephrological, and urological outcome of the patient treated for Druto. With these two procedures, we perform a meta-analysis, in particular a single proportion meta-analysis, so meta-analysis of prevalence with a subgroup meta-analysis, and for 3 papers that compare the 2 techniques, we perform an unirated approach with logarithmic odds ratio transformation. So we find 356 papers. After our review, we select 48 papers for meta-analysis. According to our results, in particular for the termination of pregnancies after the procedure, we find an effect size that was highest for the fetal cystoscopy and the serial shunting, with statistical difference between the 2 procedures. According to the intrauterine fetal death and postnatal death, the effect size are comparable, and there is no statistical difference between the 2 procedures. The main finding for form, for amnesitis, the premature birth, and also for the renal impairments of the renal function last follow-up for this patient. In particular, in this case, we can find an effect size that was highest for the fetal amniotic shunt, but there is no difference. According to the 3 studies that compares these 2 procedures, also in this case, for all the outcomes, there is no difference between the 2 procedures. So, in conclusion, our meta-analysis indicate that vesicular shunting and fetal cystoscopy show similar outcomes despite the lack of randomized controlled trials. And we think that we need to improve the fetal cystoscopy, because the fetal cystoscopy is a therapeutic intervention and also a diagnostic tools that is particularly useful in making decision of termination of pregnancy in particular cases. So we need to develop a flexibility and miniaturized technology just to improve the visualization of posterior urethra and reduce the periprocedural risk and improve morbidity and mortality outcomes. Thank you for your attention.
Presented by Dr. Tübinger from Linz, Graz, but before
I have some important, we have a little situation. The catering
is defined as urethra with over 7 mm diameter pre-vesically method. It is associated with increased risk of urinary tract infections, and the prognosis as to spontaneous resolution is favorable. So what we wanted to have a closer look into is whether the urethral diameter or the presence of visceral peristalsis during initial sonography would be a potential parameter to predict febrile UTIs, the indication for surgery, and the resolution during follow-up. So we could include 63 patients with an age and presentation in our department of under 1 year, with a mean duration of follow-up about 3 years. We define peristalsis as a visible repetitive coaptation of the urethral walls in sonography, as you can see here on the video. The second one is also the same patient, but from a different angle. So this would be a positive peristalsis. Half of the patients showed peristalsis during the initial sonography. The median diameter was 10 millimeters, and almost half of the patients had febrile UTIs during follow-up, and the spontaneous resolution in this population is about 66.6%. So we divided our group size-wise into 2 groups, one below 10 millimeters and one above 10 millimeters in diameter. And we couldn't show any significant difference regarding the occurrence of febrile UTIs and the probability of surgery in this group. The same goes with the patients where we divided in peristalsis yes or no. So also there was no significant difference in these groups occurrence according to the when talking about febrile UTIs and the probability of surgery. Taking a closer look at the spontaneous resolution rate, in our population of 63 patients, we had 42 who showed spontaneous resolution during follow-up, but there was no significant difference size-wise, and also there was no significant difference when coming to looking closer to peristalsis or no peristalsis in sonography. So the the conclusion we had to draw from our patients was that there is no clear effect of primary ureter diameter or presence of peristalsis on the probability of UTIs, fever UTIs, the probability of curative surgery, or the probability of resolution. Yeah, thank you for your attention. Are there any questions?
Ureter and the relation to the dilatation, and I will listen to your talk.
Good evening, everyone. From New Delhi in India. I would like to present a systematic review and meta-analysis on the topic of utility of urethral diameter ratio for patients having psychoureteric reflux. So, with a prevalence of 0.4 to 1.8%, VUR has no clear consensus for the conservative or interventional management, and an inadequate treatment for this disease can lead to complications like renal scarring and decrease in renal function. So, what is urethral diameter ratio? It is an objective tool which can be used for prognosis and clinical decision making. The numerator is the largest urethral diameter in the false pelvis, divided by the distance between the lower quarter of L1 vertebra and the upper quarter of L3 vertebra. So the ratio is used so as to eliminate the variations based on the patient size and the radiographic magnifications. The aim of a study is to investigate the utility of UDR as a tool for clinical decision making, to predict the outcome, and to assess the need and success of the operative intervention. So our hypothesis is that UDR is an objective predictor for the above mentioned parameters. The study was conducted by 2 independent investigators according to the PRISMA guidelines, and the studies which used UDR as a tool for clinical decision making were included. The data pertinent to the already mentioned outcomes of interest and baseline characteristics of the study were extracted. The outcomes of interest were spontaneous resolution, breakthrough UTI episodes, the requirement of operative intervention, and the success of endoscopic treatment. Statistical analysis was done, and this is the flow diagram according to the PRISMA guidelines. 13 studies were relevant and were included for systematic review. However, only 6 were pertinent for meta-analysis. The patient group which had spontaneous resolution of VUR were significantly associated with lower UDR values, and the estimated heterogeneity for this study was substantial and statistically significant. In the group with multiple breakthrough UDI episodes was associated with significantly higher UDR. However, this heterogeneity was neither substantial nor statistically significant. We could also attribute association of significantly higher UDR values in the patients who required surgery as an operative, as an intervention. And the heterogeneity was substantial and statistically significant for this outcome. The study also demonstrated that there was a significantly higher UDR associated with persistence of VUR post-endoscopic intervention. And however, the heterogeneity was neither substantial nor statistically significant. 12 out of 13 studies were of good quality, and I would like to conclude by saying that UDR can be used as an objective parameter to predict spontaneous resolution, the risk of breaking for intervention in VUR, and the success of endoscopic treatment. However, further studies are required to predict the cutoff values. Thank you. We have to define a phase of MCOG. That is why we need better studies with proper protocol determination, however, as to when to calculate the largest diameter.
Okay, thank you very much.
Thanks for the question. Thank you.
We've had a very successful meeting. In fact, in my opinion, it's been one of the most successful, both scientifically as well as socially. We've had a brilliant scientific session, especially the day one. We've never had a flat. So I want to on behalf of all of you, I want to thank Professor Thomas Wester and Carmen for organizing a very, very successful meeting. People will remember it, especially the social function as well. We had a wonderful dinner at the museum yesterday and a welcome reception there before.
Hemos terminado, amigos, el Simposio Internacional de Investigación en Cirugía Pediátrica. Ya todos se van para su casa. Yo también, vinieron desde Japón, la India, Tailandia, China, Corea del Sur, después Canadá, Finlandia. Después, ¿quién más estaba? Alemania, Países Bajos, un montón de países, amigos. Y pues presentaron su investigación, todos orgullosos de lo que están logrando. Y al año el congreso número 30, el simposio número 38 será en la China, en octubre. Nosotros ya nos despedimos y vámonos.